Welcome to the Deep Dive, where we take your source material, your crucial reading, your research notes, and turn them into instantly applicable knowledge.
Our mission today is to master the foundational language of healthcare intervention.
That's right, we're talking about prevention. So if you want to get a comprehensive, quick understanding of what really drives health policy, you have to understand where we intervene and, well, why.
That really is the starting line for everything in public health, isn't it? To get that comprehensive knowledge quickly, we have to set up a clear framework.
Okay.
We basically see prevention on 3 distinct levels, and they're all driven by a single core principle. You have to intervene at the lowest, earliest level possible.
So let's start at level 1, the ideal scenario.
That is primary prevention. The goal here is ambitious but simple. Preventing the health problem from ever happening in the first place.
Stop it before it starts.
Exactly. And this is crucial not just clinically, but economically. It is, without a doubt, the single most cost-effective form of healthcare.
Okay, so what are some classic examples of that?
Well, immunizations are the gold standard, of course. But it also includes things like lifestyle counseling, talking about home safety, wearing seatbelts, using sun protection. You're building a shield before the first threat even shows up.
And if that shield fails, or maybe we just miss that window for prevention, then we move to what you might call the safety net, level 2.
Precisely. That's secondary prevention. Here, the goal shifts from pure prevention to detection. We're trying to find a disease in an early, asymptomatic, or preclinical state.
To minimize the impact down the line.
Right. We're talking about screening, mammograms, blood pressure checks, a colonoscopy. We're finding the trouble before the patient even knows they should be looking for it.
Which leaves us with level 3.
That's tertiary prevention. And this is the response to an already established disease. The goal is just minimizing the negative disease-induced outcomes in a patient who already has a diagnosis.
So like if you have a patient with type 2 diabetes.
Exactly. Tertiary prevention would be meticulously adjusting their medication and diet to avoid future kidney or eye damage.
It seems like health economists often view tertiary care as a kind of failure of primary prevention. Does that mean our health policy funding should, structurally prioritize primary care above everything else?
That's a fantastic question. The data consistently shows that primary prevention provides the greatest societal return on investment. I mean, tertiary care is absolutely essential for quality of life once a disease takes hold, but if we're looking at the big picture, primary prevention is the optimal economic and health target.
That framework is incredibly helpful. So since primary prevention is the goal and the most cost-effective path, let's zoom in on its single highest impact strategy, immunization.
It's fascinating here because the evidence supporting vaccines isn't just strong, it's overwhelming. The bottom line from evidence-based practice is that the vaccine-related risk is demonstrably and substantially less than the risk of actually getting the disease.
And I imagine financially, it's not even a contest.
Not even close. The cost of vaccines is well outweighed by the monumental expense of treating these vaccine-preventable diseases. It is the very definition of a smart investment.
And that investment pays off exponentially because it protects not just the person getting the shot, but the whole community.
We call that herd immunity or community immunity. It works by just decreasing the overall amount of the pathogen in the population.
So it has fewer places to hide.
Exactly. When immunization rates are high, the infectious agent just has fewer opportunities to jump from host to host and spread. This means that even people who can't get vaccines, maybe because of their age or a medical condition, they get this crucial layer of protection just by living among a vaccinated population.
Let's try to bring this transformative power to life. I'm looking at some statistics on diseases avoided annually in the U.S., and these numbers really show how much chaos we've sidestepped.
They absolutely do. They drive home the scale of our success. I mean, before the polio vaccine, we were seeing the paralysis of 10,000 children and the death of 3,000 children every single year. Unbelievable. Or think about rubella. Vaccination has spared 20,000 newborns a year from congenital rubella syndrome, and that causes devastating lifelong consequences like developmental disability, blindness, hearing loss.
And even with diseases that are still circulating, the numbers are huge. The flu shot alone helps avoid something like 7 million cases of illness, 110,000 hospitalizations, and over 9,000 deaths annually. That's just staggering.
It is. And looking at the recent past, the data on COVID-19 showed that vaccination provided greater than 90% protection against hospitalization and death.
Wow.
And for anyone, concerned about the long-term effects of an infection, it also offered up to a 50% reduced risk of developing long COVID.
When we talk about being protected, we should probably clarify the difference between the two main types of immunity, active versus passive. It feels like a subtle technical point, but it's important.
It's a critical distinction, yeah, because it dictates the timing and the purpose of the intervention. Active immunity is what we get from a vaccine. The body is actively taught to build its own resistance. The protection is on board in anticipation of a possible exposure.
Yeah, it lasts for a long time.
Usually years or even lifelong. The onset is usually within about a month.
So passive immunity is more like a temporary loan of protection.
That's a great way to put it. Passive immunity is given by administering an antibody, often called an immune globulin, that was made in another host. This is typically given post-exposure to certain things, like tetanus or hepatitis A or B.
So it's a rescue mission.
It's a rescue effort, not a long-term solution. The onset is really fast, within hours, but the protection is time-limited, usually only 6 to 9 months.
Okay, so understanding the science is one thing, but how do we manage the sheer logistics of getting these shots into arms, safely and widely?
Yeah.
What are the key practical principles here?
The first principle is simple. Maximize access. You have to remove the barriers, both geographic and clinical practice barriers. Provide immunizations at schools, work sites, retail centers, anywhere people are. We have to make it easier to get the shot than not to.
And there are two really important rules of thumb about when to give them. The first one is almost counterintuitive. When in doubt, re-immunize.
Yes. If we can't confirm a patient's status, the clinical consensus is just to go ahead. The risk of a reaction with reimmunization is minimal, so it's always better to give an extra dose than to risk a missed opportunity.
And the second rule.
It's a firm policy directive. An immunization deferred is an immunization denied. You should only defer a shot in the presence of a moderate to severe illness, with or without a fever. A minor cold is not a reason for delay.
Let's try to apply this. We can slow down a scenario and walk through the logic. Let's say we have Joseph, a 28-year-old. He comes into urgent care with a clean, minor 5-centimeter cut from some glass. He says he completed his primary tetanus series, and his record shows his last Tdap was 2 years ago. Does he need a tetanus booster today?
Okay, let's unpack that. We have to look at the tetanus prophylaxis guidelines, specifically for clean, minor wounds. For this kind of wound, if a person has documented 3 or more previous doses, which Joseph does, they only need a booster if it's been more than 10 years since the last dose.
And this was only 2 years ago.
Exactly. So the correct action is no tetanus vaccine. He's well protected. We avoid an unnecessary intervention. You have to trust the patient's record and that established window.
Now, while the tetanus scenario is about frequency, we have to talk about the really rare but high-risk event that everyone needs to be prepared for, anaphylaxis. What are the genuine red flags or allergies we absolutely cannot miss?
True vaccine contraindications are rare, but we have to be ready for anaphylaxis. It's low risk, about 1 to 2 events per million doses, but it is life-threatening. That's why all vaccines have to be administered where personnel and equipment for rapid treatment are right there, immediately available.
So if it happens in a primary care setting, what are the immediate non-negotiable steps?
First, assess the ABC's airway. Breathing, circulation. Immediately put the patient in the supine position, flat on their back. Activate emergency medical services. Get them on the way.
And the first treatment?
The most crucial immediate intervention is to administer IM epinephrine into the anterior lateral thigh.
Given how many people have underlying cardiac issues, is there any scenario where we would hesitate to use epi in anaphylaxis?
That is such a critical point for clinicians, and the answer is absolutely not. There are no contraindications to epinephrine use in anaphylaxis. It doesn't matter what their comorbidity is, their age, their underlying condition, you use it immediately.
Got it.
And beyond that, of course, we counsel patients to avoid specific vaccines if they have known allergies to certain components. For instance, an allergy to neomycin means you have to avoid IQV, MMR, and varicella. Baker's yeast allergy means avoiding the hepatitis B vaccine.
Okay, let's zoom out a bit. We have to acknowledge that sometimes, despite our best efforts at primary prevention, diseases do take root. And this is where we have to shift our focus to that critical safety net.
Secondary prevention.
Right.
Yeah, secondary prevention. So early case finding through screening.
Yeah.
It has to be a critical activity in primary care, but we can't screen everyone for everything. We need some kind of filter.
What's the litmus test for that? For spending public health money? What conditions have to be met for us to justify the cost and effort of a national screening campaign?
There are 3 main conditions. First, the disease has to have a high enough prevalence to justify screening. You don't screen the entire male population for a condition that only affects women, for example. Screening needs a target audience.
If you violate that, you're just spending catastrophic amounts of money on false positives and chasing shadows.
Exactly. Second, the target disease has to have a long, recognizable asymptomatic period. If a disease goes from undetectable to dangerous in, say, a month, a yearly screening isn't going to help much.
And the third.
And third, there has to be a treatment available, and that treatment has to be known to actually alter the disease's natural history. If you find it early but can't do anything effective about it, the screening isn't justified.
We can actually see why certain screenings get prioritized just by looking at the mortality data, what's actually killing people in the U.S. When you look at the leading causes of death by age group, what statistic really jumps out at you?
To me, what really stands out and what's often overlooked is how dominant unintentional injury is. It is the #1 cause of death in every age group from 10 all the way to 44.
Wow, that's a huge span.
It is. We focus so heavily on chronic disease, but unintentional injury demands its own robust public health approach. Things like safety counseling, policy changes. That's stunning data.
It is stark. But once we hit age 45, the pattern shifts back to the diseases we usually associate with screening.
That's right. Malignant neoplasm, so cancer and heart disease, dominate the 45 to 64 age groups, and heart disease remains the #1 cause of death overall across all ages. So this really dictates where we focus our cancer and cardiovascular screening efforts.
Moving into applying specific cancer screening guidelines, the different recommendations from various task forces can sometimes feel a little overwhelming.
The key takeaway, I think, for anyone listening is to focus on the commonalities, not the slight variations. For instance, across all the major sources, there is a clear consensus. There should be no PAP or HPV testing for women under age 21, period.
Why that hard stop on cervical cancer screening before 21? Why not try to find it as early as possible?
Because women younger than 21 have a very, very low risk of invasive cancer. And critically, their immune system almost always clears the HPV infection on its own within a year or two.
So screening too early would lead to a lot of unnecessary and potentially harmful procedures.
Exactly, for lesions that would have just resolved naturally. And screening should also stop after age 65, provided the patient has had adequate negative prior results.
Let's talk about prostate cancer screening with the PSA test. That's a much more nuanced discussion.
It is. Here, we need to bring in the primary authority, the USPSTF, the U.S. Preventive Services Task Force. They recommend against screening for men aged 70 and older. That's a grade D recommendation, which means they believe the harms outweigh the benefits.
And for the group just under that?
For men aged 55 to 69, the decision should be an individualized one. It's a grade C recommendation. It should be based on their family history, their race or ethnicity, and, the patient's own personal values about the potential benefits and harms of screening.
And then there's lung cancer screening, which targets a very specific, very high-risk group.
This is a classic example of using screening where the prevalence is high enough to justify it. Annual screening is done with a low-dose CT scan, or LDCT, for adults aged 50 to 80 who meet very specific smoking history criteria.
What are those criteria?
They need to have a 20-pack-year smoking history, and they have to either currently smoke or have quit within the last 15 years.
Can you just run that through a quick example for us?
Sure. Let's say you have a 60-year-old patient. They have a 35-pack-year history, and they quit smoking 5 years ago. That person is indicated for screening. Their history and that quit window fit the criteria perfectly.
Beyond disease detection, secondary prevention also means behavioral screening. Let's start with the difficult subject of suicide. We should probably address a few common misconceptions here.
Yes. If we just look at the facts, males represent nearly 80% of all completed suicides. However, female attempts are actually 2 to 3 times more common than male attempts.
And there's a misconception about age, too.
There is. Contrary to the belief that suicide is primarily an issue for younger people, the highest rate of completed suicide is in the 75 and over age group for males. It's a shocking 40.5 per 100,000.
And the essential clinical point for anyone listening is that inquiring about suicidal ideation does not precipitate the act. It is essential to ask.
Absolutely. Another key behavioral intervention is tobacco cessation, and we guide this using the 5A strategy.
Ask, advise, assess, assist, and arrange. Let's use an example to show how this works. Say we have a 65-year-old man with COPD, and he tells you, I don't plan to quit smoking at my age. I'm too old to quit now. Why bother? How do you move past that kind of barrier?
You have to use the assess step. You don't jump straight to advising or assisting yet. You need to understand his motivation or his perceived barrier. The best response would be something like, "Tell me what you mean by 'I'm too old to quit.'"
So you open a dialogue.
You open a dialogue, you validate his feeling, and it allows you to get to the root of his resistance.
Finally, on the safety front, there's the responsibility to screen for physical, emotional, or even financial abuse.
Right. Take the example of a 75-year-old woman with dementia. She presents with some unexplained finger-shaped bruises. She can't coherently describe what happened, and her daughter, who's her main caregiver, gives a kind of vague excuse about catching her from a fall, even if the patient seems well cared for otherwise.
The bruises are a red flag.
They are. And the most appropriate next step, and your legal responsibility, is to report the incident to the local Elder Protective Service agency.
That covers the core screening activities really well. Let's finish with a highly specialized case study in secondary prevention: latent tuberculosis infection, or LTBI.
LTBI is a textbook example of detecting a disease in a subclinical state. LTBI means a person has the bacillus, but they are without symptoms of active TB, and they are unable to spread the disease.
So they're not infectious.
Not infectious, but they have a lifetime risk of developing active TB disease of about 5 to 10%. So we have to screen and treat them to prevent that active form from ever developing.
So who are the critical candidates for testing? Who's at increased risk?
People who have had recent contact with someone with active TB, also people who have immigrated from high prevalence countries, and healthcare workers.
Right.
And you'd also include people living or working in high-risk congregate settings, like homeless shelters or prisons.
The methodology for testing has shifted recently, right?
Right.
Away from the skin test.
Yes. The interferon gamma release assay, or IGRA blood test, is now generally preferred over the TST, the skin test, for all individuals age 5 and older.
And why is that?
The IGRA has several benefits that just streamline the logistics. It only requires one visit, the results are faster, and crucially, it is not affected by a prior BCG vaccination, which often causes false positives with the TST.
That makes the IGRA sound a lot more reliable.
Mm-hmm.
But if we do use the TST, especially in an older person, we sometimes see something called the booster phenomenon. What's happening there?
It's often seen in older individuals who might have been infected with TB decades ago, but their immune systems have become less reactive over time, so they might have a negative initial TST.
Oh, okay.
But that injection can boost or sort of reawaken the immune memory, which leads to a positive result on a retest up to a year later. We distinguish this from a true recent infection by using two-step testing, basically to see if that first test wakes up that old immune response.
This has been an incredibly thorough look at prevention. To synthesize this, the core learning seems clear. Primary prevention is the goal. It's the most cost-effective, high-impact strategy, like vaccination. But secondary prevention, or screening, is that critical safety net that relies on accurate knowledge of guidelines and identifying high-risk populations.
I think that's it exactly. And if we connect this all back to that initial framework, maybe consider this final provocative thought. We often celebrate and we can measure the success of secondary prevention, the lives saved by early screening, because we find the disease and we treat it, it's tangible.
Right.
But I would challenge you to consider the immeasurable societal impact of disease that never even started because of effective primary prevention. If we achieved 100% appropriate vaccination rates, or if we fully used the 5 A's to reduce tobacco use, what further systemic changes could we put in place to maximize this most cost-effective, but often invisible, form of care?
A wonderful thought to leave with, especially when considering the future structure of health funding and policy. Thank you for walking us through this deep dive into the absolute foundation of health intervention.
It was my pleasure.
And thank you for joining us. We hope you feel thoroughly well informed. We'll see you next time.